Okay, good afternoon, everybody. I think we'll go ahead. We have a sufficient number of people in.
Good afternoon, Doctor.
Yes, we'll go ahead. We have a sufficient number of people in the class to continue. So today we'll talk briefly about smoking-related pulmonary disease. This is a very broad subject as well, because it also includes an introduction to smoking cessation. Let me see where you are close to. Okay, great. So we can get started. So smoking is the one of the most important preventable causes of disease globally. What I'm showing you here is a global map of the distribution of smoking by country, and what I mean, it's a graphic representation. You can appreciate from these that Kenya lies between 10 and 15% in terms of prevalence of smoking among men and women 15 years and above. This is a similar representation showing the average smoking prevalence in Africa is about 13%, with a very high, a much higher proportion of males as compared to females. You will appreciate that in the more developed parts of the world, the proportion of cigarette smoking among males and females is the difference is narrowing. So it's estimated by the World Health Organization that between 700 million and 1.3 billion, sorry, this is billion, that's an error, of 1.3 billion individuals around the world use tobacco smoking. Globally, about 12% of annual mortality is attributable to diseases that are related to tobacco smoking. So looking at the mechanisms of disease causation in cigarette smoking, there are three main ways in which cigarette smoking contributes to disease. One is through the direct contents of the cigarette smoke itself, consisting of oxidants, aldehydes, various acids, ammonia, and so on, which cause local irritation of the airway epithelium, resulting in injury and death of cells and influx of macrophages and neutrophils, and these leads to a chronic inflammatory response. The other mechanism is through impairment of the mucociliary clearance system, which we have previously also talked about, and also through direct toxic effect, but also through the inflammatory response, you get impairment of mucociliary clearance, leading to accumulation and retention of mucus, and which gets secondarily infected. This does directly contribute to the vicious cycle of inflammation, but also now considered to have a role in carcinogenesis. The other arm is through also the oxidants, aromatic hydrocarbons that are found in cigarette smoke, nitrosamines, and so on. And these will affect various stages of the cell cycle, leading to oncogenesis and carcinogenesis. And this is what gives you lung cancer. There's obviously a direct interaction between chronic inflammation and carcinogenesis. Chronic inflammation is responsible for chronic obstructive pulmonary disease, which is actually the prototype smoking-related pulmonary disease that we'll be talking about today, and the many other inflammatory lung diseases which we will just mention. Okay, so these are the mechanisms of the various pulmonary diseases that you see. Obviously, you just talked about lung cancer, so we will not be discussing that. So in terms of classification, we have the airways diseases that are related to smoking, cigarette smoking or tobacco smoking. And these fall under the umbrella of COPD. But the two entities that form under the umbrella of COPD are emphysema and chronic bronchitis. Then you have interstitial smoking-related interstitial lung disease. The examples here would be obstructive bronchiolitis, respiratory bronchiolitis, interstitial lung disease, desquamative interstitial pneumonia, pulmonary Langerhans cell histiocytosis, and acute eosinophilic pneumonia. So these are, relatively quite rare, but important to identify in the context of cigarette smoking. Then we have a combined pulmonary fibrosis with emphysema and also lung cancer, which you have talked about. So for purposes of this class, we will be discussing COPD. The other smoking-related lung, particularly the interstitial lung diseases, are very, very rare, but it is important for you to be aware about them, so that when patients present in a typical manner in the background of pulmonary disease, it's important for you to think about these conditions. Lung cancer you have discussed, and we will not discuss it any further. So COPD, in terms of definition, is pretty common. It is preventable, it is treatable, and it's a disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and or alveolar abnormalities, usually caused by a significant exposure to noxious particles or gases. So the key words here is that this is a fairly common disease. It's preventable in many situations, and if diagnosed early, it is treatable, it's manageable. Unlike asthma, which we talked about previously, COPD, the symptoms tend to be persistent. The airflow limitation is usually incompletely reversible, and usually progressive. And the key pathological processes that give you these manifestations are related to airway and alveolar damage. Okay, and usually there is a prominent history of exposure to noxious particles or gases. When you look at global statistics, COPD is the fourth leading cause of mortality. It is estimated that about a quarter of a billion people have COPD globally, and it contributes to about 5% of all deaths also globally. In terms of prevalence, it's obviously much higher in those who use tobacco smoking products. It is higher in those who are 40 years of age and above. It is also higher in men compared to women. Other risk factors, in addition to tobacco smoking, that increase the risk of COPD include environmental tobacco smoke. So this is secondary tobacco smoke, as would occur in a household where you have a member of a household who smokes and the rest of the household does not. It would occur in professions where people that work in that environment are exposed to others that smoke. So you're thinking here about people that, you know, the waiters and the hostesses in you know, bars and so on. Exposure to biomass fuel is an important cause of COPD in our setting, and we'll be mentioning something briefly about that. Occupational exposures, alpha-1 antitrypsin deficiency, those are really well-established causes of what? Of COPD, or established risk factors. Other probable risk factors would be environmental air pollution, pulmonary TB, poorly treated asthma, intrauterine growth retardation, poor nutrition, repeated lower respiratory tract infections, especially of childhood. Others such as age, male gender, and a low socioeconomic status. So these are examples of the tobacco products that can cause pulmonary lung, or pulmonary disease that you need to be aware of. And as we have said, biomass fuel exposure is a very important component or very important risk factors of COPD, especially in our setting. And what this illustration you see in the right upper corner is really that this is a risk factor that can start very early on, of course affecting the mother, but can also affect a child if they are exposed in the same manner as the mom. And then below on the right lower, what you see is a mining establishment, and that kind of occupational exposure to occupational dusts can also be an important risk factor for COPD. Other risk factors that we mentioned include environmental exposures, especially pollution related to the urban environment. So heavy, poorly maintained motor vehicles, motor vehicle traffic, as you would see commonly in most of our large urban centers. What you see on the right upper is an establishment where people burn tires to retrieve wires for metal wires for recycling. And you can imagine that all the smoke that comes from burning of rubber tires and the consequence in terms of environmental pollution. What you see on the right lower, on the left lower, is an example of a typical example in you know, a large city with uncontrolled standards of emission. So is the photo on the right lower corner. This is an example of dust exposures. This individual was careful to protect his eyes, but as you can see from that diagram, the nose is not protected. So a very important risk factor for COPD exposure, chronic exposure to occupational dusts. So COPD is a fairly expensive condition to have, both for individuals, but also for health systems. So as you are able to tell from what you have here is, you have direct costs that are related to management of these patients, but you have also indirect costs that are related to disability, the years lived with disability, with disease, and also premature mortality. So what are the disease modifiers in patients that have the risk factors for COPD or that have these exposures to known risk factors for COPD? These would include genetic factors, age and gender, lung growth and development. So for instance, we know that prematurity is a risk factor for COPD much later on in life. Exposure to particles, socioeconomic status, occurrence of asthma and airway hyperreactivity, chronic bronchitis, and as well as infections. So how do these things converge? So you have etiological risk factors in the context of host enabling factors, including impaired lung growth, accelerated decline in lung function, lung injury, and lung and systemic inflammation, giving you small airway disorders or abnormalities, emphysema, which is the irreversible dilatation of the alveoli and the destruction of the alveolar walls. And then you have systemic effects, giving you physiology that is related to airflow limitation and clinical manifestations that we will talk about, characterized by cough, shortness of breath, expectoration, exacerbations, as well as comorbidities. So this is an illustration of the manner in which lung function as measured by FEV1 changes over time from birth. Obviously, it cannot be zero. Then you have in the second decade, that's adolescence to the early 20s, maximum growth in lung function, and then with a peak in the late 20s to the mid 30s. That's why most of your elite athletes are people in their late teens and the early 20s. After that, there is a peak in lung function, and then it starts to have a natural decline. But this decline is such that without disease, generally speaking, people will not experience impaired lung function because of age. What smoking does is to accelerate the rate of decline in lung function. Okay, so that's really what is important in smoking. The natural decline in lung function is accelerated in COPD. So in terms of presentation, the common respiratory symptoms include dyspnea, cough, and sputum production. The main risk for COPD, obviously, as we have said, in patients who present with these symptoms, usually insidious, is tobacco smoking. So you need to establish whether they have a history of tobacco smoking, and also look out for other environmental exposures such as biomass fuel, air pollution, and occupational exposures. The course of the disease is usually punctuated by periods of acute worsening of respiratory symptoms, which we refer to as exacerbations. So in terms of evaluation of these patients, the first thing you want to, the objectives for evaluation include determining the level of airflow limitation, which gives you an indication of the severity of the disease. Assess the impact of disease on the patient's health status. So how has the disease limited their activities of daily living, including the social and occupational engagements. Identify comorbidities. Assess the risk of future events, particularly exacerbations, hospital admission, and death. And really, this evaluation should help you guide the treatment that will be offered. The evaluation, as usual, proceeds with a good history, a physical examination, and investigations. The most important investigation in COPD is spirometry, which is now, as per the guidelines, a requirement. And what you want them to demonstrate is an FEV1, FVC ratio of less than 0.7, and which remains persistent, so is not completely reversible on bronchodilator use. So the important aspects of the history is to establish the pattern of symptom development. As we've said, it's usually by the time patients present to you, it is chronic. Establish the patient's exposure risk factors. Establish the presence of comorbidities, the impact of disease on patients' life. Get a good history of exacerbations and previous hospitalization. Past medical history obviously is important. Family history of COPD or other chronic respiratory conditions. You want to establish the social and family support, including whether the way, the means by which the patient pays for their health care, and then establish the risks, the possibilities of reducing risk factors, especially smoking cessation or clean cooking energies. So we mentioned comorbidities in COPD because they are very, very common. And the commonest conditions associated with COPD include arterial hypertension, diastolic dysfunction, diabetes, pulmonary hypertension, obviously lung cancer, atherosclerosis and the associated diseases like coronary artery disease, other vascular conditions. So these are very, very common, and when you are evaluating your patients, you want to ensure that you are establishing whether or not they have these accompanying comorbidities. So this is a schema of how you want to proceed with the evaluation. So you have your symptoms, ensure you have an understanding of the risk factors. There is almost always a risk factor in the context of COPD. We have already indicated that you need spirometry, it's a requirement. The key symptoms are dyspnea, which is usually progressive over time. It is exercise exacerbated and is persistent. Usually have a chronic cough, maybe intermittent and maybe unproductive. It's not always productive. There may be wheeze. There's chronic sputum production, and the quantity would increase during exacerbations. And patients generally report recurrent lower respiratory tract infections because, as we indicated previously, they have impaired local immunity to infections, and then establish risk factors that we've talked about, and take a good family and social history. In terms of differential diagnosis, they can be either pulmonary or extrapulmonary. Pulmonary important differential diagnosis would be asthma, lung cancer, tuberculosis, bronchiectasis, which we discussed the other day, left heart failure, interstitial lung disease, cystic fibrosis in the right context, and idiopathic cough. Extrathoracic differential diagnosis would include chronic allergic rhinitis, postnasal drip syndrome, upper airway cough syndrome, gastroesophageal reflux, and don't forget medication. And really these extrathoracic differential diagnoses are related to chronic cough. So these are conditions which present with the chronic cough. So in terms of management, what are the components of management of COPD? A big component is what we refer to as pulmonary rehabilitation. Education, so that you empower the patient to provide themselves with what we refer to as self-care or self-management, integrated care and palliative care. There's also non-invasive ventilation. So when you get back to us in the 6th year, we will talk details about the therapeutics of COPD. But important aspects of COPD management can be classified into pharmacologic and non-pharmacologic. Non-pharmacologic aspects include health literacy and counseling. So people always have to be given information about their condition and what they can do about their condition. If therapies are going to be provided, the importance of adherence to therapies. If there are other non-pharmacological therapies that are going to be given, then patients need to be given the opportunity to understand why they need to implement those non-pharmacologic therapies. And then 2, there is elimination of exposures for those whose main risk factor is smoking, or those who are use cigarette smoking. Then you need to institute smoking cessation. There are 2 forms of smoking cessation interventions, that's counseling and pharmacologic interventions, and we'll talk briefly about those. And clean cooking in the context of smoking that is related to exposure to dirty cooking fuels, and obviously elimination of occupational exposures where the main risk factor is an occupational exposure. So smoking cessation strategies We know that providing brief strategies can help patients quit cigarette smoking. So the first thing is to, we have these 5 A's, ask. So this is to systematically identify all tobacco users at every clinic. So every opportunity you have to take a history from a patient, you should always establish whether they use tobacco products or not. Then advice, which is to strongly urge all tobacco users to quit, provided in a clear, strong, and personalized manner, to urge every tobacco user to quit. Assess is to determine willingness and rationale of a patient's desire to make a quit attempt. Here, ask every tobacco user if he or she is willing to make a quit attempt at this time or within the next 30 days. To assist is to aid the patient in quitting. So help the patient with a quit plan, provide practical counseling, provide intra-treatment social support, help the patient obtain extra treatment social support, and recommend use of approved pharmacotherapies for tobacco cessation. And then finally arrange, which is schedule a follow-up visit, either in person or through telephone. So these are the 5 steps we use to help our patients to quit smoking. So how do you apply these interventions? So you want to identify patients who are at low risk for continued smoking. For those patients, you want to start off with counseling. And where counseling doesn't work, then you want to move on to add on pharmacologic interventions. For patients who are at high risk for continued smoking, those ones you need to have counseling together with pharmacologic interventions. They are unlikely to stop smoking on their own. Okay, now going back to COPD, how do we manage COPD? The question you want to ask yourself, is it stable or unstable? So if it is stable disease, the goals for treatment are to reduce symptoms and to reduce risk. To reduce symptoms, we do this by relieving symptoms. We'll mention something about that. Improve exercise tolerance and improve health status. To reduce risk here, what you want to do is to prevent disease progression, prevent and treat exacerbations, and reduce mortality. So the pharmacologic therapies for COPD, the main objective is to reduce symptoms, reduce frequency and severity of exacerbations, and improve health status. The treatment should be individualized and usually guided by severity of symptoms, risk of exacerbation, side effects, comorbidities, availability of the agents, as well as their costs, patient response to the agents, and preference and ability to use various drug delivery devices. Okay. So this is an illustration of the main agents that we use for management of COPD. So short-acting beta-2 agonists, which including the main one in our setup is salbutamol. Okay. The common side effects are related to their non-selective nature for the beta-2 receptor. So you will have palpitations, tachycardia, insomnia, irritability, tremors, and hypokalemia. Then we have long-acting beta-2 agonists, such as formoterol, salmeterol, and indaketrol. And the side effects are the same as for short-acting beta-2 agonists. We have short-acting anticholinergics like ipratropium. The main side effect of these is dryness of the mouth. Yeah, sorry about that. Then we have a combination short-acting beta-2 agonists and anticholinergics, such as salbutamol and ipratropium. Okay, these are also given as inhaled therapies. And their risk factor is that of upper respiratory tract infections and headache. We also have long-acting anticholinergics like tiotropium, which will give you a dry mouth. Okay. Inhaled corticosteroids like beclomethasone, budesonide, and fluticasone, which give oral candidiasis and skin bruising, these side effects, and a combination of the long-acting beta-agonists and inhaled corticosteroids, and the phosphodiesterase 4 inhibitors like roflumilast. So how do we follow up patients who are diagnosed to have COPD? You want to provide these patients with the influenza and pneumococcal vaccinations, provide pulmonary rehabilitation. If you have patients who have severe resting chronic hypoxemia, then long-term oxygen therapy improves survival. And in patients with severe chronic hypercapnia and a history of hospitalization for acute respiratory failure, these patients may benefit from long-term non-invasive ventilation. We've talked about the pharmacologic agents that we use, and really the key aspect of COPD management is a removal of number one, prevention, and globally, the one that will have the greatest impact in reducing or preventing COPD is a reduction in cigarette, tobacco smoking, and the use of tobacco products. That's smoking-related tobacco products, and obviously a reduction in environmental pollution. So thank you. That is an overview of COPD. I would, if you have any questions, you can go ahead and ask, but look at the chat and see if you have anything. So Najma, when you said chronic cough, that's predominantly unproductive, and when chronic production, what is the difference there? I don't understand the question, but what we are saying that COPD, the cough is chronic, can be dry or productive. That's really what we are saying. And the COPD is an important differential diagnosis of chronic cough, whether productive or non-productive. And the main differential diagnosis of COPD all have one common feature, which is chronic cough. Okay. Do you have any other question? Okay, so in the absence of any other question, I think we can call it a day, would request the class rep to get in touch so that we can give you arrange for makeup sessions for the lectures that were missed. Thank you.
Thank you, Dr. Mecha.